Warm welcome to everyone. My name is Barb McCaffrey. I'm the CII CPAR project lead with the Alberta Medical Association Accelerating Change Transformation team. I also want to welcome my co-host today, Sheena George. Sheena, do you want to introduce yourself?
Thanks, Barb. Hi, everyone. My name is Sheena, and I am the CII CPAR primary care lead.
Great. We're going to be your hosts this afternoon. Do want to mention, if you have never used Zoom before, welcome to the technology. There is a chat functionality. Thank you all for introducing yourselves. We will be monitoring the chat as we go today to see what questions you have. This session is being recorded, and we'll stop it later on, and we can, at that time, you can come off mute and come on video if you want to ask questions. So welcome everyone. So we are here today to introduce you to CII CPAR, Community Information Integration Central Patient Attachment Registry. And this is an orientation specifically for clinic managers, and it is for clinic managers of primary care and pediatrician clinics, because from an IT side, it's the same for both those offices. And we will be offering a session for specialist offices as they don't use the functionality for the Central Patient Attachment Registry, just community information integration, and we'll be offering that at another time. So let's give you a little bit of an introduction of CII and CPAR. CII and CPAR were at the request of physicians in Alberta. It was the section of general practice, which is now the section of family medicine, that requested a registry to record which patient was paneled to which provider in Alberta. Specialists were requesting the technology to submit consult reports to Netcare from their community clinics, and that became a motion at AMA Representative Forum. So physicians asked for it, and Alberta Health made the commitment to build this tool and make it available. So why do we need this technology for continuity and integration? In primary care, the College of Family Physicians of Canada created a vision for the patient's medical home. There's foundational functions and development that is occurring in the patient's medical home. Continuity of care is one of the important pillars of the patient's medical home. In Alberta, we created an implementation model to achieve that patient's medical home. This model is based on the safety net medical home model, but contextualized for Alberta. One of the key implementation steps is panel and continuity. We know that for continuity of care, there are multiple dimensions to continuity: relational, which is foundational, informational, and management continuity. Management continuity is achieving those smooth transition of care where all providers have the right information to them and they can manage a patient based on their context and values. So CII CPAR was created as that technology to support integration and continuity. So we are working together with our partners to implement Community Information Integration Central Patient Attachment Registry in primary care for clinics associated with primary care networks. We're providing supports to PCNs mainly through the training of improvement facilitators that are then able to guide a clinic and support them in implementation. The eHealth Support Services team at Alberta Netcare play another crucial role as they hold the hand of the clinic through confirmation of participation through Go Live. So let's dive into what are CII and CPAR. They actually are two separate pieces of technology. CII is the system that allows the collection and information from EMRs in the community to Alberta Netcare. We are copying information to another place in Alberta called the Healthcare Data Repository. It's new, and it's a database that can use this information for quality improvement and system planning. Just so you know, the Healthcare Data Repository is governed in Alberta by the Health Information Data Governance Committee. It has representation in Alberta by physicians as well as other providers whose data may go there, including nurses and pharmacists. CPAR is a separate piece of technology, and this is a database that captures the confirmed relationship of a primary provider, family physician, nurse practitioner, or pediatrician, and their paneled patients. Through the new technology, automatically on a monthly basis, it's able to receive information from clinic EMRs. It really is the next logical step for clinics that have already been involved in panel management. And you'll see how foundational it is for the technology that we have, or some of it's already enabled, such as e-notifications. So how does CII and CPAR work? So this is the overview. On the left-hand side, you can see that there are 3 types of information that can go from the clinic EMR to the data hub. So those are encounters, consult reports, and patient panels. When the clinic is connected and enrolled in the program, the data goes from the EMR on a nightly basis to the CII data hub, where it gets uploaded to NetCare. And there it will be in 2 forms, a clinical encounter digest or a consult report. As well, on a monthly basis, the same technology allows the panels to go through the CII data hub to the Central Patient Attachment Registry, and all the information, the encounter and the panel information, gets copied to the Healthcare Data Repository for analytics purposes. Importantly, in the middle is the provincial client registry that validates that the patient identification is correct and it's getting matched up correctly. So because of CI-CPAR, when a clinic participates, they share 3 things: panel lists, encounter data, and consult reports. In return from participation, they receive 3 things: a demographic mismatch report, panel conflict reports, and e-notifications, which I'm going to tell you a little bit more about. They also enhance NetCare in the process, but more importantly, creates information available for Albertans where others in their circle of care can access that. And that information is in the form of something called a Community Encounter Digest and consult reports. So let's dive in and look at those 3 types of information and how it works. So the first type of information is called the encounter information. So select fields in the EMR is mapped to flow from the EMR through the data hub to NetCare to form this item called the Community Encounter Digest. The CED is designed to be a rolling 12-month snapshot of a patient's encounters in the communities. I'll show you that in a moment. Again, I mentioned the information is copied to the Healthcare Data Repository. Now, one thing that physicians are very often concerned about when they hear about this is how do they keep information confidential? Importantly, there's 2 ways to do that. So number 1 is that only mapped fields transfer from the EMR to the Community Encounter Digest. And before participating, every provider is educated on what those fields are in quite a bit of detail so they understand how it goes. The second way is if a provider needs to document in a mapped field but wants to keep the information confidential at the clinic, each EMR has functionality that allows that information to remain at the clinic. And patient records can be confidential at the whole record level, a visit level, or often in individual fields. So where do the Community Encounter Digest sit in NetCare? Actually, as of today, about 150,000 Albertans have a Community Encounter Digest in their NetCare record as a result of visiting a clinic that is enabled on CII. And it sits in a report folder that was created a couple of years ago called Community Reports. So this is our sample of the Community Encounter Digest, and I'll go through what it contains so you get an idea of the very specific and distinct information that it is pulling from the EMR. So the first section is called the community encounter information. It includes the date, place, and provider that the person saw, the role of that provider, and you can see here that our example says general practice physician, but we have also, of course, other providers such as nurses that can contribute in this area. It'll include the reason for encounter, which it pulls from usually the scheduler of the EMR, and the assessment coding that the provider put on that visit. If nothing is recorded in the visit for a given field, it does not pull to the CED. The second area is called the health concern history. A more common term for this area is probably the problem or profile item in the EMR. So if a new problem is recorded in a visit, this gets recorded and shared with the Community Encounter Digest. Allergies, if they're recorded in a visit, get pulled as well. They're called possible allergies because they are not required to be verified. Measured observations pull, specifically height, weight, blood pressure, and waist circumference. If immunizations are delivered at the clinic, it pulls from that area as well. If during that visit a referral is initiated, it will pull the type of referral. So in the example here, you see it's urology and cardiology. So it doesn't specify the physician so much as the referral type. This is quite useful information. Imagine a patient that goes to an emergency department or a walk-in clinic for a given concern. Another provider can see that that concern has already been seen, perhaps by another physician in the community. And as well, if they initiated a referral for the type of referral needed, they might see that the referral has already been initiated. There is a disclosure statement on the bottom, and it indicates that the information in the Community Encounter Digest is as it is in the rest of Netcare, which is simply called as is. Okay, so the second type of information that can be sent to Netcare are consult reports. Any type, this isn't just open to specialists, but any type of provider that receives referral requests and write consults reports can submit them to Netcare. This one's really simple. A copy of the consult report that is also faxed back to that referring provider gets pulled out of the EMR and a PDF copy sits in Netcare. Providers have complete control over which consult reports they decide to share. The third type of information are panels. So for family physicians or pediatricians or nurse practitioners that have a panel, those lists from the EMR get moved on a monthly basis from the back of the EMR to the Central Patient Attachment Registry. Once a clinic is registered, they'll provision somebody in the clinic that has permissions to go to the Central Patient Attachment Registry, which is a secure web portal, and download 2 reports. Those 2 reports are the demographic mismatch report and the panel conflict report. The demographic mismatch report has 2 parts. The first page indicates patients on the panel who've become deceased since the last monthly upload. The second part of the report indicates demographic information that isn't a complete match with the provincial client registry, and it's an opportunity to do some cleanup there. The panel conflict report represents patients on the provider's panel who have said yes to the panel question at another clinic, and that provider is also participating in CPAR. It indicates, of course, the demographic information of the patient, the last confirmation date, and the last visit date for both providers. This is really useful information for clinics that want to identify patients that might be receiving duplicate care. So how this occurs on a monthly basis varies a little bit by EMR. TELUS uploads automatically on the 10th of the month. QHR uploads automatically on the 12th of the month. And HealthQuest users have a manual submission. Once a month, one person clicks a button that submits the panels, and that has to be done by the 21st of the month. Starting on the 22nd, CPAR starts to manually do its work to look for the duplicates. Usually within 2 days after upload, there are some reports that are available called the error reports available to the clinic. But the other main report that they're looking for are the panel conflict reports, and they're available starting the 2nd of the next month. Okay, so let's tell you about e-notifications, because this is a really exciting feature of CII CPAR, and we're already getting some exciting patient stories about it. So e-notifications are automatic notices that appear in the EMR when a CPAR paneled patient has had an emergency department discharge, hospital admission, hospital discharge, or day surgery. Most day surgery, but not 100% of day surgery sites are submitting in Alberta. But for the rest of them, any AHS facility in Alberta of those types will start to send the notification. These work 7 days a week, and they are sent at 6 a.m. and 2 p.m. on a daily basis. They appear in the EMR very similar to a lab report, although this example that you're seeing is MedAccess, and it does come in as a task. So once the e-notification is opened, it includes the patient demographics, the facility location where it occurred, the date and time, the attending provider, the admission reason, and if that patient is paneled to more than one provider in Alberta that is participating in CPAR, it will indicate additional providers notified. And this is an opportunity to follow up with the patient, not only about their hospital visit, perhaps, but also their panel conflict. So this has been live in MicroQuest HealthQuest, TELUS Wolf, and TELUS MedAccess. Next to go live is PS Suite, and we're expecting that in August, and QHR later this year. So how many e-notifications are physicians receiving? On average, we have about 1.5 per provider per day. Although I can tell you that looking at the data, we see that that number is lower in the urban settings and higher in the rural settings. When you look at it based on panel size, if a provider has a panel of 1,000 patients, they would see on average 11 per week. You might be wondering how this looks like in your EMR, and we have details for Wolf, MedAccess, and HealthQuest available on our website with very specific information. So here's a real patient story from one of our early adopter physicians, Dr. Heidi Velt in Calgary. And this happened during COVID. So she had a young patient that had visited the ER 3 times in a week. And Dr. Velt saw the notice. And she saw that in her EMR through the e-notifications. And it was because she was dehydrated because she was using too much cannabis. Each time she went into hospital, they addressed the concern and rehydrated her, but really weren't able to deal with the underlying anxiety that was causing all of this. Dr. Fell contacted her. The patient was actually surprised because she didn't expect it, but she was happy that she had done so. And she offered her a couple of virtual visits and able to address the underlying cause of the emergency room visits. This is another real patient story from a provider that is participating, but from both sides, the hospital and the physician office. And we received this story from our Health Quality Council evaluators who were speaking to a hospitalist. So it begins with a provider that chooses to participate in CII CPAR. That provider is choosing to participate, and their visits are recorded in the clinic EMR and uploaded to the Community Encounter Digest in NetCare. The provider saw a patient in the clinic for a given concern, and that concern was recorded in the Community Encounter Digest. This patient ended up quite distressed with the concern and ended up going to the emergency in the local hospital. At the local hospital, this happened in a geography where much of the area is implemented on CII CPAR. One of the first things that the physician did as in emergency was look up in Alberta Net Care. And there the physician saw the community encounter digest. This was really an important event for the emergency physician when they were reporting it to the Health Quality Council of Alberta. They described that they don't get community information. And this was remarkable for them because they had seen that this patient had already been seeing a primary provider in the community for the very concern that they had come into the hospital for. And this completely informed the visit and changed the approach of the emergency doctor. They made some decisions based on what they were going to do for the patient, provided the care at the time, recommended that the patient go back to their patient's medical home, but at the same time, the e-notification would go back to the primary provider to alert them as well, so they could follow up appropriately. So we're really excited that the functionality is doing exactly what it's supposed to be doing. So before we move any further, now that I've talked to you about the different types of ways that participants can participate, here are the options. So when you have providers in your clinics that are a family physician, pediatrician, or a nurse practitioner with a panel, they're asked to submit panels and encounters, and it's optional if they want to submit consult reports, depending if that is part of their practice. Any physician, nurse practitioner, or actually an allied health professional, a good example are chronic disease management nurses. These are people without panels, but they book appointments in the scheduler. They can submit encounters and consult reports if they offer them. Community specialists, it's optional for them to submit encounters, but they sign up to submit their consult reports to Alberta Net Care. So this is where we've been and where we're going with CPAR as well. So there is some additional functionality that is planned, and some of this is in development. So one of the pieces that's in development is the identity of the primary care provider in an Albertan's Net Care record. So basically, a patient who's attached to a provider using CPAR, it would say in their Net Care record who their family physician is, or pediatrician or nurse practitioner. So that work has already started in the form of collecting the requirements. The second piece that hasn't started but is a planned functionality is the ability for the primary care provider, who's the provider that knows the patient the best, to create something called a patient summary report. This would be curated at the clinic, customized by the clinic, and then it would be uploaded to Net Care and sit there much like the consult reports do from community clinics as well. And it's anticipated that physician offices would want to do this for very complex patients so that others in their circle of care could have access to it should they end up going to a clinic that's not their medical home, emergency, or hospital. The intent of that also is as well, and you can see here at the bottom, is that it will be shared to the MyHealth record, and a copy would be made available through MyHealth for the Albertan. Okay, I'm going to pass it off to my co-host Sheena to talk about the current progress.
Thanks, Barb. There's a couple of questions on the chat line that I thought it was important that we highlight. So Ali, I'm going to go into more detail about the PIA and whether there is a need or not for a consultant. So when I get to those slides, if I haven't given you the information you need, I'll do a check-in with you. And Lori, you had a great question about the Cancer Institutes in Alberta. The e-notifications are very much about the coding and how things are going forward. And I'm going to pass this over to Barb to give you a little bit more detail about whether or not cancer care is actually participating with the e-notifications today.
Yeah, thanks, Sheena. Good question. So the e-notifications are all based on the coding that happens in the visit at the AHS site. And as I mentioned, the ones that were chosen were hospital admission, discharge, ED discharge, or day surgery. But most of the visits at the cancer sites are outpatient visits, and they were not included. Having said that they're not included doesn't mean it can't change. There'd have to be a sponsor for that as well. It would have to be considered by a clinical work group that makes those decisions. and then chosen to put in the system. But for now, they're not. The other news is that cancer sites, as they move to Connect Care is being implemented in AHS facilities in Alberta, will be uploading more of the notes that maybe they didn't in the past because they weren't on Connect Care. So that will provide greater integration to Netcare once those sites move on to Connect Care. I don't know how many times I can say the word care.
Not enough times. You have to love when systems choose the same words to describe different things, right? Not like making it easy for us. Thank you, Barb. Okay, so now you know what CII CPAR is. You've heard about some patient and provider stories. Let's look at the current progress. What does our rollout look like? So on the next slide, thank you, Barb. Let's look at the footprint. So when we look at the data that's flowing across, so Barb has talked about what community clinics and teams are sharing, we can see that we have data from over 400,000 patient encounters, and those have been submitted to Netcare today. And this data is as of June 1st. So looking at that, that represents over 100,000 unique patients that have now shared and uploaded information to Alberta Netcare. And that's in that form of a community encounter digest, that snapshot report that Barb just reviewed with you. So for the consults, since June, over 40,000 consult reports are now in Netcare. So usually consults are only being sent to the referring physician. So this is where we can really see over 40,000 is now available. Same with when you think about primary care, over 100,000 unique patients now have CEDs in Netcare as a result of their clinics participating. On the next slide, we'll start to look at the geography. So if we looked at deployment by PCN and by zone, and this data is from as of the end of May, we have 53 clinics associated with the PCN that are now live, and an additional 24 specialist clinics. So in total, for physicians, there's over 300. We're at 336 physicians, and that's across 85 clinics in Alberta. So how about some evaluation data? So as Barb had mentioned earlier, the Health Quality Council of Alberta, HQCA, has done an evaluation on the project. And they just published a report, and it's quite recent. And that report has a bunch of surveys and interview data with clinics and participants that are live. And so what we found on our next slide is that onboarding with CII CPAR, when we asked participants, they said was it resource intensive for our clinic? So I want to make a distinction here. The resource intensive is not about the cost for CII CPAR participation, because there is no cost. It's free participation, and it's free access to the provincial systems. What it means is, tell me about the time and the effort. What does that look like? So when they asked and they surveyed the respondents, they found that 38% strongly disagreed that this onboarding was resource intensive, and 41% agreed that it was resource intensive. So we're not going to lie, there's a lot of paperwork. There's paperwork, and it is administrative. And so that's the space where we know that there's going to be needing some time and some effort. And we'll talk a little bit more about what that could look like. On the next slide, we asked, or they had asked, so when you think about time and resources, tell me what that would look like. So they wanted to know about the practice changes. So if you're participating and you're a clinic manager or a team member and you're asking your physicians and team members to start to participate, what do the practice changes look like? And were those overly burdensome or difficult? When you looked at the survey data, 86% indicated that the practice changes were not overly burdensome. And instead, what they found that it actually was relatively easy to be able to participate and move forward. So what they did need to look at is especially the EMR and how team members are entering information within the EMR. So that was our main one that we heard back from them. They also talked about if there was conversations with patients about patients' medical home, because again, if you remember, coming into CII CPAR, it's important that patients understand that they're looking at the panel and having that confirmed relationship. Participating also means you're starting to get conflict reports back. So there's also the opportunity to start to look at some of these reports. So you'll need to think about your processes there as well. So on our next slide, we have some stories and some examples from a clinic that's already live. It's coming out of Big Country PCN, and I do see some other clinic managers on this call from this PCN, as well as some others that are live as well. So please do chip in on, and provide some feedback on the chat. So this quote, why we really like this quote is it's very realistic, and it's balanced. When this PCN, the clinic, decided to join, there was an opportunity for individual physicians or just a few to join. The whole clinic decided they wanted to go. They knew that right off the bat. So they started the process, and immediately what the challenge there was realizing, okay, we needed to set some dedicated time to do the paperwork. So trying to go through the paper at the side of your desk is going to take you a lot longer, and it's going to be a lot more frustrating. So that was definitely one of their first lessons learned. But once they got through the paper, it was immediate for them to be able to see the benefit, because as soon as they got that conflict report and they were looking as a team, they could identify where they could make an impact. So for them, it was really about looking at the end game and what they were able to accomplish by participating that got them through. So what are the prerequisites? So what do we need to focus on if you want to start to participate in CII CPAR? There are 4. First off is you need to be live on Netcare. So what that means for a clinic is it's the clinic being live. You could have physicians and team members who don't have Netcare access, and they're having their MOAs or other team members pulling information from Netcare for them. That's fine. As long as the clinic is live on Netcare, you've met the requirement. So a PIA, you need to have a PIA that's up to date in order to go live. But you don't need it to be up to date to start the process. It's a really important distinction. And Ali, it's to go back to your question, it's important that they have a PIA, and you'll work with the eHealth support team. And I'll talk to you more about what that looks like. The third requirement is being panel ready. So this is not about having a certain accuracy rate of confirmation. It's not about having all of your panels absolutely clean. It's about that there's a person, there's a process, and you're using the EMR as your tool to document that process for panel identification and maintenance. So really it's about saying that you're starting this, or you're well into the process of looking at your panels and working through it. In terms of EMRs, so in our province today, there are 85% of community EMRs are one of the conformed EMRs already that are participating today. So MicroQuest, HealthQuest, QHR, Acuro, TELUS MedAccess, PS Suite, and TELUS Wolf. So all of the TELUS products, Acuro and HealthQuest, these have all been conformed and are able to participate today, and are. So on our next slide, we get a lot of questions about privacy. And it's important that you understand that there's a lot of support tools available to you. So CII CPAR fits under the Netcare umbrella. And because it's under the Netcare umbrella, it follows the Health Information Act. So what that means is, just like with Netcare participation, with CII participation, you're not required to have direct conversations with patients. And actually what you do need to do is have a health collection poster. And some of you may already have a Netcare one. And so when you look at the document that's provided for you, and the link in the screen here is an actual template of this poster, it's meant to replace that one. It has Netcare information as well on it. And it essentially is just, that's all you need to be able to post. Or on your website, you could have a message, or if you have an advertisement in your waiting room, it could be, something could be placed on that as well. The desire is that there's just information available. Now, if you have patients that do want to have questions, or you know that they're going to have questions, we've produced a patient brochure that's accessible to you. And if conversations are required, again, there's a script that's supported with the team as well. If there's still more questions, there's a 1-800 number and an FAQ, and there is an eHealth team that would help address some of those questions. So really the point of this slide is to tell you that there is no requirement to have that direct conversation. You're covered under the Health Information Act, but if there are patients that you feel need more information, you have a lot of different tools at your fingertips. So thinking about that privacy and security requirements, one of the other pieces of information that always gets asked is how, when you look at our EMRs, and even though Barb has described that it's only select information, it's mapped information, it's reminding your physicians and teams again that that mapped information will be available to you. There's support tools so you can actually see prior to going live what exactly the fields are and how it looks. And so that when you know, if you don't want information to go because you want it to stay confidential, you could just put it in an unmapped field, or you could enable a confidentiality flag within your EMR. All of the EMRs that are conformed today have training tools that show you how to do that. And like I said, or you just choose not to document in a mapped field. When you look at what's in NetCare, there's also an opportunity to mask the client record. So it can never, it doesn't have to leave the EMR, or within NetCare itself, it would be masked. So when we started the project back in 2017, AMA was asked to conduct a patient survey. We used Alberta Patients First. And they asked specifically, what did patients think about this project? And patients already had assumed over 70% of them already thought this was already happening. So they think more sharing is happening than it is. And they're thinking that because every time they come and see a physician or team member, they're in front of a computer. So often they believe that information is coming across the system. So going through the survey, when we gave a detailed explanation of what CII was, over 93% approved the project. That's a very high approval rate when you think about some of these different IT projects. And what their concerns was who would have access to that information, and if there was security from hackers or patient consent. So as we know, because again, we're under the Alberta NetCare umbrella and there's a privacy impact assessment specifically for the project, we follow all those security protocols. And so it is a secure system. On our next slide, so I mentioned that, so panel readiness isn't about a confirmation rate, it's about having that identification and maintenance processes in place. So a tool to support you as your clinic manager and your team members is a checklist. This checklist is available to you, and really it goes through, do you have the processes in place for a team member when your patients are coming in, that you're asking them a question, is this your most responsible provider? Is this who you see doing your screening and doing your follow-ups? And if that information is getting date stamped and entered into your EMR, then you're well on your way of being able to participate. So this checklist is there to help guide clinics and teams to assess that readiness. If you can say yes on everything on the checklist, you've met that requirement. On our next slide, we're going to talk a little bit more about some more testimonials. So this is a quote that we received from Dr. Joseph Ajetikin. He's from the North Zone. And what he was talking about a patient experience that he had during COVID as well, where a patient that he had known quite well was experiencing some back pain, and he knew that he was going to be going in for surgery. He didn't hear back from that patient for some time, and it was about a year or so later where the patient showed back up, and he actually had some complications with that surgery, and he ended up being paralyzed from the waist down. What Dr. Ajetikin, where we got that quote, is when he said, CII CPAR really is the best thing for continuity of care, because without having that ability to know his patients are in and out of hospital or ER, he doesn't have the ability to do that proactive care. He was very shocked to see his patient and see that he had such a negative experience. So it was something that really resonated for him, and why he felt it was so important, so important to participate. So another testimonial that we've seen is coming from Dr. Chris Lay, and this is from Ideal Medical in Edmonton, in the Edmonton zone. So Dr. Lay is starting out his panel, and he's been working on his panel processes and working with his PCN to get the HQSAFE panel reports. And so as he's in the process of that and participating, his question was, well, okay, so I'm getting these HQCA panel reports because I want to understand my panel size and burden of illness and social deprivation. These are all the things I want to start to work on. So if I start doing CII CPAR, what's the benefit of that? And so in this quote, he sees that it is a huge benefit. This really is the most accurate way to validate and share his panel information. And it helps him also understand if patients are no longer on the panel. So that demographic mismatch report, when that now starts coming into the clinic, he's able to see when his patients have deceased. So it helps his team understand where to start updating his EMR and accurately starting to update the patient's demographic information. This is helping him with his cancer screening or his chronic disease. So from his perspective, when he was looking at the time and energy, because yes, you will need to look at your processes and you're going to get some information back to you, he thought the investment of time and energy up front was it's a low maintenance system, and it was because it was highly automated, it was a true way of enhancing and supporting that care. On our next slide, we want to go into a little bit more detail here about, as a clinic manager, what is important for you to know. So Barb had introduced that you have team members around you. So what are the things that are specific to you in your role? So I'm going to pass this over to Barb.
Thanks, Sheena. Yeah, so we're so glad we have this clinic manager audience today, and we want to share what we think is important to you from our experience in working with clinics to date. So the first thing you might be asking is, what are my roles and responsibilities and roles and responsibilities of others with respect to this? So we have created a roles and responsibilities document to help outline what those are. And first of all, we have spent quite a bit of effort, and we're available to the primary care network facilitators or other type roles that you might work with as a clinic manager. And they should be really working as your guide, because they are familiar with the project and know what happens on a step-by-step basis. But there are 3 other important roles that I want to go over with you. So the first role is what we call from the project is the site liaison. For clinics that have a clinic manager, it is often the clinic manager that performs the role of the site liaison. And they are the prime contact between the clinic and eHealth support services during go live, but also afterwards as the lasting contact. We do recommend that a clinic have an alternate site liaison, knowing and hoping that everyone takes holidays, that they have a backup contact at the clinic. The next role we call the CPAR Access Administrator, and I'm sure many of you on the webinar also play the role of the Netcare Access Administrator. Because these are all secure applications, there is quite a bit of similarities between what has to happen in Netcare with what has to happen to CPAR. So somebody at the clinic plays this role and has the ability to provision users at the clinic of the Central Patient Attachment Registry. And that brings us to the Central Patient Attachment Registry Panel Administrator, the CPAR Panel Administrator. This is a person at the clinic. It's quite often somebody that might be in a panel type role, and their role is to log into the CPAR secure web application at least once a month to download the reports that are available and used at the clinic. So the CPAR Panel Administrator is provisioned by the Access Administrator, and the Site Liaison, in summary, is the main contact. So you're wondering, what are some things that I might have to do, or me and my team might have to do during the experience for CII CPAR? Well, early on in the process, we call this stage engagement and interest. And if you have a PCN facilitator, we'd like you to contact and work with that PCN facilitator partner. The next important activity that has to take place at the clinic is to receive and review all the information with respect to mapping in the EMR. Because it's really important that all team members that are contributing, including the physicians, know what fields map to the community encounter digest. You'll probably be working with the physicians on that decision to participate, and identify the site liaison, who might be yourself. The next thing would be to find your privacy impact assessment. We recommend that you complete something we have called a privacy impact assessment update self-assessment. So it's a checklist tool, it's a questionnaire that can allow you to identify what needs to be updated in your privacy impact assessment. The next step would be to complete the confirmation of participation form, and we'll get into that in a moment, and that gets submitted to eHealth support services. Once the COP is submitted, the clinic is in the next phase called registration and participation. And during that time, we need to identify team members to be the access administrator and the CPAR panel administrator. The site liaison will liaise or communicate with eHealth support services and each clinic gets a dedicated consultant that is the contact throughout the whole phase. The next stage is a lot of form completion. And honestly, if a clinic is participating in both CII and CPAR, there are more forms because there's a lot of paperwork for the CPAR application than a clinic that is participating that doesn't have any panels and actually won't be participating in the CPAR component, but just the CII component. And at that point as well, once the COP form goes in, an eHealth privacy specialist will call the clinic and meet with the designated person for a privacy impact assessment, risk assessment. Sheena is going to talk a little bit more about that in a bit. So there's also in the middle, when we say that the access administrator will provision users for the Central Patient Attachment Registry, the access administrator will use Identity and Access Management, or IAM. If you're already using Identity and Access Management, then this isn't going to be new information for you. But not only do you provision users for NetCare using IAM, you provision users for CPAR as well. So after go live, what does it entail that the clinic manager and team will do? The go live date is coordinated between the clinic and eHealth support services. So there's that opportunity to schedule it at a good time for the clinic. Once a clinic goes live and the first panel gets uploaded, there will be that opportunity to retrieve and review the panel conflict reports, review them with a physician, and then give feedback as a team and develop processes for dealing with them. Also, once the first panel has uploaded, the clinic is live with e-notifications, and there needs to be a process at the clinic to deal with those e-notifications, and probably the whole team will get involved in that, decide what is physician work and what is teamwork. Also, after go live day, somebody goes into NetCare and finds a patient that had been in the previous day and views the community encounter digest for some quality assurance. And it's that ability to make the connection between data input and output on the community encounter digest. I will say that some clinics have found out, and when Sheena was mentioned, where one of the chief practice changes that occurred was data entry. The one area where clinic teams that have already participated have found that was in the area of data entry in the scheduler. And some clinics were also using those fields for inter-clinic communication, where they might say patients coming in for a sore throat, oh, and they'll be 10 minutes late. Well, if that information is not deleted, it does go on to the community encounter digest. And this is where clinics saw that they were doing that and able to make the connection between data entry and data output, and they may have had to revise their clinic processes. And a good example is in MedAccess, where clinics do that, and instead of entering that interclinic communication information into the reason for visit field, it's entered into the notes field. The next thing after go live is the clinic is offered the option to complete an evaluation. And then we do recommend quality and process improvement meetings, hopefully with your PCN practice facilitator. So at this point, you might be thinking, oh, we're interested in participating. Sheena, how about you take them over into participation?
Sounds good. Let's move on to our next slide and show what our visual looks like for our process. Okay, so Barb has gone through the process. You've heard what it sounds like. Here's visually what it could look like. So right off the bat, the first thing that starts off your registration is getting that confirmation of participation form submitted. That's your first piece that you need to get completed. You're going to go online, and Barb is going to review what that looks like for you, so you'll get a good sense of how to do that. That usually, let's say it takes about a week or so. You can see the timelines on the graphics here of what the estimates would be. Then you start to get a package back sent to you. So this is what kicks off, that COP kicks off the whole process. The registration package is where you're going to see that information that you need to sign from your physicians and team members, and try to start to identify who's going to be your panel administrator and signing off your panel request forms. At each of these visual stages here, when you start to get the participation package and you submit them, there's a checklist that comes from eHealth, a checklist and a person who will walk you through your process and be your point of contact as you're going through. So as throughout this whole piece, you do have someone who you can have questions and answers with if you do need some assistance. At the end of that participation package, when you've submitted all your signed forms and submitting it through a fax, what will happen is you will start to get your panel identification numbers. And then at this point is where you can start to do that EMR configuration. Again, we have a guide that shows you exactly what you need to do, and a checklist as well to make sure that you have all the steps in place. Once that gets configured, you are ready to start sharing your data. Now, we often get the question of how long is the process in total, because we all know we're working with physicians and it can take quite a while to get signatures back and forth. We can't really give a sense of what that would look like, but let's, if you got your signatures quite quickly, it could be about 6 weeks to longer to be able to go through the whole process. A part of what this will be is testing and making sure you're looking at your data in Netcare. So that's about an estimate of where we are today. On our next slide. So again, going to that COP form, what will be really important to remember here is the question about the privacy impact assessment. So when that COP form goes in, a key document for you to review and to submit with your COP is the PIA self-assessment. And the reason that that's important is because the moment the COP goes through, you'll be assigned an eHealth privacy consultant, so a subject matter expert on privacy. They will ask you for your PIA self-assessment. If you haven't completed it, that's fine. It'll just mean a little bit longer conversation. But what they do is a free service, and it's a risk assessment service. And what that risk assessment does is it helps you determine if you have a minor or a major update for your PIA. Now, the benefit of that is going to help you understand if you do need to hire a privacy consultant or not, or if you're able to move through with what you have already. So on the next slide, let's talk a little bit more about that PIA. So what's a minor update versus a major one? So something that's a minor update is something like physicians are leaving in and out of your practice. You're going to remote access, or you're getting Wi-Fi in your clinic. Those are all considered minor updates. Minor updates, you're able to go straight through and participate with CII and CPAR. Your eHealth consultant in that assessment will advise you on the things that you need to change for that minor update, and you have up to 12 months to do those changes. Quite simply, it's usually just having a policy document about a breach, the breaches that are happening in Netcare, and who you would go to report those breaches, or to be able to have a one-page letter to tell the OIPC that you have changes in your physician. So those are some examples and tools that they would share or direct you towards. If it was a major update, one of the changes that have happened now is that even with a major update, as long as you've submitted that new or that major update to your PIA, you can move forward. Prior, it was you needed to have a response back from the OIPC that major PIA update was accepted. So now it's important to know your minor PIA updates, you move forward and you're able to participate. The major ones, as soon as you've submitted it, at that point you can go. If it is major, that's when they will let you know if they recommend that you hire a privacy consultant to help you with that piece. Ali, does that, is there any questions on this one for anyone on the call? Perfect, thank you.
Tina?
Yes.
I just wanted to, we have a privacy officer within our organization with the PCN who looks after all of our organization PS. So am I safe to assume that she would be the person, like our privacy officer would be the person that would go through the PA review with whomever is assigned to us?
Yeah, that's a great question, Kelly. And I'm so glad you raised that. And that's it's all the important piece when you do that COP and you're identifying who's the primary contact. So who's the site liaison, if that's yourself and you have an alternate. That's when eHealth will connect with you, Kelly, if that's who you are in that role. And they will ask you to set up a phone call with them. At that point in time, absolutely. If you have a privacy officer, connect with them and have them have that phone call with the eHealth consultant, because it will, these phone calls can be up 10 minutes up to an hour to do that risk assessment. So if you have someone in the role, that's who needs to have the conversation.
That's perfect. Thanks so much.
Good question. Okay. Thank you, Ali.
All right, so Shana, we're going to move live to the web, and I am going to show everyone how to complete, or first of all, where to find, and then a little bit about the confirmation of participation form. So first I'm going to show you where to find it. And if you go to act.albertadoctors.org, the easiest way to get to the CII CPAR webpage is to go to Patient's Medical Home and then on CII CPAR. And here we have multiple versions of our web page. Want to point out we have a great news page, lots of stories from other providers if some of your physicians want to hear that. But on our primary care tools and resources page, we have a forms and agreements section, and we have two forms. We have a confirmation of participation form for up to 10 participants, and there's another one for up to 25. When you open the form, it is an online PDF form, and we want clinics to complete it on the computer, and then it gets sent to eHealth Support Services. What we don't want clinics to do is completing it by hand, because that makes it difficult to read by eHealth Support Services, and then they might ask it to be redone. So the form includes the clinic information and address, the facility ID and or what's called the WDFA key. If you have it, contribute it. The clinic person that does billing usually knows the facility ID, and I'm sure many of you are administrators in the EMR as well, and you would know that information. If the clinic's associated with a PCN, we want to know what that PCN affiliation is. And if there's no PCN affiliation, there is a checkbox for that. We do want to know eHealth Support Services is regularly working with the PCN improvement facilitators or practice facilitators or similar roles. So if you can mention your PCN facilitator on the form, that is also important. And initially, so today after this meeting, if you're interested in moving ahead, we do recommend you tell the PCN and talk to your PCN facilitator or similar type role. There's a drop-down menu to select the EMR that you are using. And there's another question about, is the EMR shared? Now you should know this, but if you don't, you might need to speak to the clinic EMR administrator. We know that we have some clinics out there that are on what's called a shared database. And in that case, they have one EMR, and many clinic sites that actually operate on the same EMR because it's a server that's in the cloud. And if you can name those clinics that you share the EMR with, that is quite helpful. Then, as we mentioned before, the next thing that you're going to identify is the site liaison, likely yourself. And we need a backup liaison, hoping that you will take holidays at some point. So the identity and contact information of the primary and the alternate liaison are identified. To help eHealth Support Services, they do want to know if the clinic did already complete that PIA update self-assessment. There's some tick boxes there. And if you already have an idea if you need to update the PIA that's based on that assessment, and if you know the last date that the EMR PIA was updated. if the clinic is live on Alberta Netcare, and if the clinic has a panel, if you've already done the panel readiness checklist, and hopefully, yes, you have already done that. In this section, identify the names of the participating providers. So this could be physicians, but also non-physicians. So if you have a CDM nurse that books in the scheduler, and the encounters from that nurse are desired to be contributing to the community encounter digest, that nurse can sign up. So we already have nurses, pharmacists, other types of allied healthcare providers that are signing up and contributing. For each participant, identify the PCN affiliation. We do know that some clinics have providers with more than one PCN affiliation, and that needs to be identified. And then what type of information are they expecting to participate? Encounters, panels, e-notifications. And if they are uploading consult reports, we do want to know the specialty of that provider that will be uploading consult reports. Page 2 of the form asks about governance with respect to custodianship of the records. And if you have a primary custodian at the clinic, or each provider is their own custodian. So we know that some clinics are organized in a way that one physician is in the role of primary custodian, and the other physicians at the clinic allow that physician to take on the role of primary custodian. We have other clinics that aren't organized that way, and each physician is a custodian. And the reason it's asked for here is it has an impact to paperwork. The next two sections ask for the submission of the initials of the person completing the form to indicate that there has been a sharing of the mapping information, an understanding of what goes to Netcare and the healthcare data repository, have been already shown or looked up the features of how to use the confidentiality features. Also, if the clinic is a TELUS clinic, EMR mobile will need to be turned on, even though the clinic doesn't use it or isn't using it. It's part of the functionality to make this work. And understand that their vendor might be going into their, well, not might be, will be going into their EMR to configure it for CII CPAR. Part F indicates that the clinic has read through the materials and that the information related to privacy, roles and responsibility, the CED going to Netcare and panels has all been discussed with the clinic. And then once this is all done electronically, it just gets emailed to eHealth Support Services, and they're ready to accept it and take the clinic on to the next steps. So I'm going to pause here and just take a look. And the chat's not appearing for me today, Sheena. But are there any questions we need to ask or answer?
No, we are good.
Okay, well, I'm going to go back.
Actually, no, you know what? I want to just highlight something that our colleague Sue has highlighted for everyone on the chat and on the call today. It's just a reminder that to download the form first, because if you don't, you'll lose information, as she has learned the hard way.
Thanks for that tip, Sue.
No problem. I just want everyone to learn from my pain.
Okay. All right, and let's see. Can you see the PowerPoint, Sheena?
Yes, I do. All good. Thank you. Okay, so let's look at another quote that we received. This is coming from Edmonton Zone. I really like this quote. It's very recent. This clinic went live on COVID, went live on CII CPAR during COVID, the early stages of COVID. Can't believe I can say the early stages of COVID, but it really has been, what, almost 4 months now. But she had 2 patients that were pregnant, and she got an e-notification as soon as she was live on CII CPAR. This is Dr. Janet Craig. And that e-notification showed that both patients on separate days were discharged from the obstetrics. So she went into Netcare to make sure, okay, did they actually have the baby or was it something else? And so once she had confirmed that, she she had called her patient, so she had an opportunity because of that notification for some proactive care, and she connected with them and said, left them a message to give her a call back to schedule an appointment for within the next couple of weeks to see how baby and mom were doing. Now, the next day, both of them had called her immediately, and it wasn't going so well. They were having some concerns with breastfeeding, and right off the bat, Dr. Craig was able to connect them with the Healthy Beginnings nurse, and then do a follow-up call with them. So it's just being a mom myself, remembering what it was like having my first child, thinking what an opportunity during COVID, when Dr. Janet Craig talks about her patients, she found that in the beginning, many of them didn't realize she was still open and that they could reach out to her and see her virtually. So this was the benefit she saw with the notification. It just allowed her the opportunity to reach out when it was required. Let's move to our next slide. So what are the next steps and what are the support tools that you have if you're wanting to move forward with your clinics? Where are you going to get that support? It's important to understand, Barb talked about you have a team involved with you as you're going on your CII CPAR journey. So what does that look like from a project perspective and a high level view? So what we have here, we call this a RACI. What a RACI is it breaks down what are the roles and responsibilities of people that are involved in initiatives and trying to move work forward. The R is the person who's responsible to actually do the work. And A is someone who's accountable for that work, so making sure that it gets done. C represents those that are consulted. Who do you go back and forth with if you have some decisions to make or you need some input? I is for those who are informed. So who would you want to keep informed where your progress is? Now, for the engagement and the training for PCNs, AMA is responsible. We're accountable to offer that training. And as you all are attending the clinic managers training today, you see the PCN's role is a responsibility then, if they're coming to these training sessions with you, to make sure that you feel that you are well supported and you have the information that you need, and that they're consulting back and forth with you to say, is there any other things that you need to feel confident to go ahead? Once the clinic engagement happens, that's when our PCN teams go into our clinics and identify and say, these are the clinics that we think we want to move forward with right away. They've raised their hand. AMA is consulted to offer any kind of support there as well. That accountability sits within the PCN to make sure, again, that their teams are well informed and prepared. To attend the training or making sure that the COP is filled out correctly, and so as Barb has reviewed. So those are the things like making sure the responsibility of the clinic is that your physicians and team are well aware of the mapped data elements and they feel comfortable sharing that data, and that they understand that they need to put a health collection notice poster up and they don't need to have those direct conversations. So that's where that responsibility of translating that information with your physician and team sits. If you are in a PCN managed clinic, you can see the difference there. The accountability is with the PCN. Is with the PCN and responsibilities with the clinic. The accountability is with the clinic there because it's a PCN managed clinic. So on terms of our clinic go live, what would that look like? So again, during that whole process of once you've submitted that COP, you have an Alberta Health person that's attached to you. So when you see AMA's role, we go into a consulting role, and the PCN is responsible as your guide is going through your whole process with you. Clinic is accountable, but now you see Alberta Health has a responsibility here because they will be the ones that are walking you through that process and making sure that your data is flowing as it should be. For post-implementation support, it's the same thing. So now that you see that, again, you have Alberta Health there who's going to be the ones that will connect you. So if you see your error reports, for example, or you're noticing something is off in Netcare, then they are the ones that are going to reach out and help you and support you in that space. On our next slide, we'll talk about the importance of knowing who your PCN contact is. So because we're all on Zoom and we want to try and see if this is going to work. If you go to your reactions on the bottom of your Zoom, screen, do you see a thumbs up and a hand there? If you can give me a thumbs up if you know who your PCN contact is, or if you want to put that in the chat as well. Perfect, thank you. Now, if you don't know your PCN contact, do you know your PCN facilitator? And for those of you who don't know who that is, or if you are in a clinic that is not part of a, okay, perfect, thank you so much. If you are not part of a PCN, you can still participate in CII CPAR. And we would like you to use the email inbox on the screen here to to express your interest. And it's CII-specialty@albertadoctors.org. So if you're in any one of these spaces and you're not sure who your contact is, please, for non-PCNs, please use the inbox. And if you, I think I saw everybody here raise their hands. Just gonna look here. Okay, thanks, Victoria. Perfect. Okay, let's go to the next slide. There's a lot of resources that are on our website, and we have, it's called Primary Care Tools and Resources. So this is the link here. When you go to the website, and if you move on to the next slide, this is where you're going to see a lot of the detailed support tools that are available. So for example, we have an actual clinic journey checklist, and that is going to let you see all the different responsibilities along the way and at what part of your journey. So this will become a tool that, as this clinic manager, if you are the site liaison, it's going to become your best friend, because it'll help you understand, okay, so what do I need to do next? Who do I need to contact? Everything is hyperlinked, so you'll be able to get to any checklists that are that would be useful at that time. There's also, for those of you who like to see things visually, we've created a process map that also details out what the process looks like. And as I mentioned at that RACI, where we talk about who's the responsible person and who's accountable along the different phases, we took that same checklist and broke it out. So as a team, you can figure out, okay, as a clinic manager, these are the forms that I may need to do, or I've delegated this to someone else and the team is going to do the forms, but I'm also now going to be the panel administrator. So you can identify where you are in the process and what steps you actually need to do. So that clinic journey checklist just breaks that down for you in that way. Barb has gone through in detail what some of the privacy and security. We've talked very much about the data mapping. So what you see on the slide here today is an EMR orientation presentation. We've pulled out some slides from that presentation. Now your PCN is sending quality improvement team members for the full CII CPAR training. You're here today to have the version that's directed specifically for you as clinic managers. Now your QI teams will have these orientation presentations, they'll have gone through them, but you have access to them too. And they actually have all the screenshots of each of the EMRs, specific EMRs, and shows you how the data is mapped across. We've just put the recordings of these sessions. It's about 1 hour long. So if you're interested in looking at that or hearing that recording, you have the option to do that as well. So that COP form that Barb showed you online, so it's annotated in that slide deck, so you can also see again the reminders of how do you fill out the form, what is the importance of the field, and where do you get the information if you need any reference information. Now if you feel like you understand that mapping, there's also a shortened version of EMR specific recordings. They're just under a half an hour that you also have access to on our website, that you can use that to just get familiar again, to understand, because data mapping is super important, and often that's where the barrier is. So it'll be important to look at those tools and understand that when you're having your conversations. Now the overall guide for the entire support tools is this team toolkit. So that team toolkit again is aligned to that RACI document we showed you. You'll be able to understand when in the team toolkit, what phase are you on? Are you doing the form phase? It'll go through the form phases and hyperlink you back again to all of the different forms, whether they're annotated in the checklist that go along with it. Sorry, everyone. I feel like I'm losing my voice a bit here. So what are some other CII CPAR experiences? We've received quite a few different testimonials and feedback sessions, and it's been coming from across the different zones. We're hearing from cardiologists who are seeing immediate impacts of having their consult notes and then your reports shared in NetCare, because now they're hearing back from ER physicians who have the ability to contact them directly when the patient shows up in ER. And there's what we've heard from Dr. Steve Tilley is that there was patients where he was able to have those direct conversations with the ER and not have them re-refer the patient to a different cardiologist, and they can make some decision making right there and then when it was most appropriate to do so. We're hearing from Calgary Zone about family physicians that are specializing in chronic pain or addictions and mental health, and specifically from Calgary's Bow Valley PCN, of physicians there that were working very, very closely with the ER. It was a small community where patients were going back and forth from ER to the clinic. And the ability to share the consult reports reduced their need to even start printing off the paper consult reports and paper charts and sitting down and have ER meetings. They were able to just, where they were to go into net care at the time, they were able to do that. So from them, it was very much about patient safety. We're hearing from our clinics who are starting those panel processes and realizing that now when they're seeing their own data come back and seeing the conflict reports, it's helping them work with their teams and see what the value is of making sure they understand how everyone's entering information into the EMR and looking at that standardization, or looking at their panel processes again and trying to understand where they can tweak and make some improvements. So this really is the first time many clinics are seeing their own data in the form of clinical reports. And it's the first time they're seeing that information in NetCare, where other providers in the patient circle of care are accessing them. So we're hearing from these teams specifically that this is where they've seen the value of having the EMR data entry conversation. As we all know, clinics are using their EMRs in many different ways. And this is a tool that's helping them to see where that they could have the potential to change. So we've gone over all of the requirements to participate in CII and CPAR. We've talked to you about what it actually is and shared some stories with you. And most importantly, went over that first form, the COP form, as that is what triggers on your process and allows your team to start moving forward. So here's where we are at and asking some questions. So I'm going to go to the chat line, or for anyone who feels comfortable, please come off camera. We'd love to see you and hear from you as well.
And Sheena, I've made you host, so can you stop the recording as well?
Sure can.